Okay, here is a 20-year-old female who came with a one-day history of severe pain in the left leg after involvement in a road traffic accident. Yeah, so she was on a border and they got this accident. So after that accident, she couldn't use the limb. She had severe pain in the leg, but she could feel the distal parts of the leg. Those are the toes in the feet. Of course, as you can see, it is swollen, it is shiny, showing those signs of active inflammation. It was tender on touch, but it wasn't having that crepitus, so showing that the fragments were not many. Then it was not also clinically deformed, though radiologically we shall see how it was showing. Then our toes had a normal motor and sensor response, plus the ankle and the knee joints were also intact. Then these are the x-rays of this patient. Yeah, on your left is the AP view, on your right is the lateral view. You can see the knee and ankle joints proximally and distally, respectively. Then the tibia is the bigger bone, then the fibula is the smaller one. And then in this bigger bone, which is the tibia, you will see that oblique line, that fracture line which is oblique in the middle third of the tibia. Then from the relation of the distal fragment, you can as well see that it is medially displaced, because the medial side is the side where we have the tibia. For the fibula, it is intact. Then the distal and the proximal tibiofibular joint, they are also intact. And then these are some of the recordings taken as we are applying the complete and split POP cast, because we needed something that will cover a larger circumference of the limb but still accommodate the swelling. That's why we opted for a complete and split. Then later on, we shall change to a fiberglass when the swelling settles down. Then the positioning of this leg, we applied it below knee first, which we later completed to an above knee. Below knee because as we are trying to reduce this angulation before applying the cast, this gravity, as it pulls the distal fragment, the gravity assists us by adding more traction downwards on the distal fragment so that the alignment is maintained as we are trying to correct that medial angulation at the fracture site there. So we apply cotton first to this limb before we unroll the POP bandage onto the leg. Why? Remember, we have different types of cotton. We have this one that is already sorted in 2 layers, the organized one, the so-called undercast padding. Then you also have this ordinary one. So the relevance of cotton is, one, it will be for comfort purposes. Remember, this cast is going to harden, and this hard stuff is going to be rough on the skin. So there need to be something in between the cast and the skin so that we don't have that roughness on the patient. Then secondly, absorption of that heat that is emitted. Remember, the cast sets by emitting heat in that exothermic reaction. So there needs to be something in between the cast and the limb or and the skin to absorb that heat. But the good thing, it just stays for a few minutes after setting. Then the third one is to do as a shock absorber. Remember, this cast is going to attain or to remain in the same size attained during the time of application. But this is a fresh injury which is going to reduce in size as the inflammation settles. So there will be sagging in the next few days. So this cotton will be there to act as a shock absorber so that the cast doesn't excessively sag. Then the other one can be around to cushion those bony prominences. Remember, we have bony prominences. And this cotton is hard, and this POP is hard to bony prominences. So you don't want to compress them, and you create ischemia for the tissues to die, and you create pressure sores. So we shall need an extra padding, one extra cushion to the bony prominences so that we avoid those pressure sores as well. These are recordings captured during applying the below knee part of the cast, which was later modified to above knee and split to make it a complete and split. Then use the bandage to maintain its integrity.